Before we start with our other presentation, we recognize that many Indigenous nations have long-standing relationships with the land upon which the work of the University of Toronto's Department of Medicine is conducted. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississauga, the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we are grateful to have the opportunity to live, work, and gather on these territories. Land acknowledgements are only a starting point for larger conversations. A donation was made to the Native Women's Association of Canada on behalf of our Journal Club gatherings over the past year. We now turn to Dr. Carolyn Tan, PGY4, a geriatric medicine subspecialty resident and future clinical pharmacology resident, to present a meta-analysis on periodontal health, cognitive decline, and dementia. Carolyn, please feel free to share your slides and begin.
Thank you for the introduction, Dr. Gandel, and good morning, everyone. My name is Carolyn, and today I'll be sharing about periodontal health, cognitive decline, and dementia. So growing up, my mom told me that poor dental hygiene can cause dementia. Recognizing this as a very poorly disguised attempt to get me to take better care of my teeth, I said, yeah, right. But seeing the title of this article, it got me wondering, was my mom actually onto something? So today we'll be using the systematic review and meta-analysis published in the Journal of the American Geriatric Society in September 2022 to help us answer this question. I do not have any conflicts of interest, except I really didn't want my mom to be right. So today we'll be outlining the relationship between periodontal health and cognition, critically appraising this study, discussing reverse causality, and considering implications for our daily practice. Periodontitis is the inflammation of tooth-supporting tissues. It affects about 70% of older adults in Canada. It's more common in males, those with low socioeconomic status, less than a high school education, as well as those who are currently smoking. In severe cases, which occur in 10% of older adults, periodontitis leads to tooth loss, making it one of the leading causes of tooth loss in our older adults. There are various proposed mechanisms for how periodontitis impacts cognition, but please note that all of these require further study. Periodontitis leads to chronic systemic inflammation, which may promote neuroinflammation. Reduced sensory motor stimulation from the muscles of mastication from tooth loss may lead to atrophic brain changes. Periodontal pathogens may have a direct impact on the brain, and tooth loss can lead to decreased nutrition, which can impact cognition. The objective of this study was to examine the available longitudinal evidence concerning the effect of poor periodontal health on cognitive decline and dementia. The authors included longitudinal studies of participants without dementia at baseline. There was no age criteria. The exposure was periodontal health, which could be measured in a variety of ways, including tooth loss, probing pocket depth, PPD, which is the distance from the bottom of the periodontal pocket shown there up to the top of the gingival margin, clinical attachment loss, CAL, which also goes from the bottom of the periodontal pocket up to the junction of the crown and the root surface, or alveolar bone loss, ABL, shown there. The two outcomes of interest were cognitive decline and dementia. The authors chose the more general term cognitive decline in an attempt to capture the full spectrum of cognitive changes not severe enough to impact function. And this was done given the variability in how cognitive impairment was defined across studies. They excluded case reports as well as cross-sectional studies. The authors searched 5 databases up until April of this year. They also searched reference lists of the included articles. They only included English language publications, and eligibility was determined by 2 independent reviewers, with disagreement settled by consensus discussion with a 3rd reviewer. To avoid pooling different types of effect estimates, the authors used the most widely used effect estimate for each outcome, which was odds ratio for cognitive decline and hazard ratio for dementia. They computed random effects pooled estimates with 95% confidence intervals and I-squared for the degree of heterogeneity. To assess the quality of the included articles, risk of bias was assessed in 4 major and 1 minor domain, and each article received a rating of good, moderate, or low in the following categories: population representativeness, study duration, exposure assessment, outcome assessment, and subject attrition. And it was the combination of these that was used to generate an overall rating of good, moderate, or low quality for each study. Taking a look at what they included, the authors found 24 studies of cognitive decline and 23 studies of dementia for inclusion in their systematic review. All of these were population-based longitudinal studies published between 2001 and 2022, and most studies were conducted in Europe or Asia. Several studies included participants under the age of 65. 9 studies of cognitive decline and 15 studies of dementia included these younger participants. The mean follow-up period was 7.2 years for studies of cognitive decline and 12.4 years for studies of dementia. Because the authors chose to include only studies that reported the most widely used type of effect estimate, only 10 studies of cognitive decline and 13 studies of dementia could actually be included in the meta-analysis. Taking a look at how they assessed for exposure, there was some variability in how periodontal health was measured. Some studies used standard diagnostic criteria for periodontitis, and some studies used individual clinical measures for periodontal health, and these were both considered good quality exposure assessments. Some studies used tooth loss from dental records, and this was considered to be moderate quality since tooth loss can arise from a variety of causes aside from periodontitis. And other studies used self-reported measures such as tooth count or gingival bleeding, and this was considered to be a low quality exposure assessment. Taking a look at how they assessed the outcomes, there was some variability when it came to the assessment as well as the definition of cognitive decline. The majority of studies did use some sort of comprehensive test, such as the MMSE, the MoCA, or TICS. One study used a recall test only, and one study used the combination of word fluency and the digit symbol substitution test, and both of these were still considered to be a good quality outcome assessment. And 2 studies used only a subjective assessment, either performed by a nurse or self-reported by the patient themselves. In terms of how cognitive decline was defined, definitions varied from incident MCI to a decline of 3 or more points on MMSE or MoCA, to a subjective decline in cognition, to specific scores, for example, a score of 0 to 1 on the 3-word recall. There was more consistency for dementia, as all studies used some sort of standardized criteria, most commonly the DSM or ICD. Taking a look at the results, this forest plot includes the results of 10 studies and demonstrates that poor periodontal health was associated with cognitive decline, with an odds ratio of 1.23 and an I-squared statistic of 70%, representing substantial heterogeneity. Taking a look at more results, this forest plot includes the results of 13 studies, and it shows that there was also an association between poor periodontal health and dementia, with a hazard ratio of 1.21 and an I-squared statistic of 95%, representing considerable heterogeneity. So as we saw in the forest plots, poor periodontal health was associated with both cognitive decline and dementia. It was also associated, tooth loss was also associated with cognitive decline and dementia, with an odds ratio of 1.23 and a hazard ratio of 1.13 for dementia. Partial tooth loss was associated with only cognitive decline with an odds ratio of 1.5, and complete tooth loss was only associated with dementia with a hazard ratio of 1.23. The periodontitis specific measures were not associated with either outcome. Taking a look at the critical appraisal, was this a systematic review of randomized trials? No, it was not, as they only included observational studies. And this implies a higher risk of reverse causality, that is cognitive decline or dementia contributing to poor periodontal health, as well as confounding. Common methods to account for reverse causality include removing individuals with prevalent disease, as well as the use of longer follow-up periods, as this reduces the proportion of participants where cognitive decline or dementia likely develops first, and therefore cause poor dental hygiene. To account for reverse causality, the authors did perform an additional analysis of dementia studies that had at least 10 years of follow-up. Unsurprisingly, they found an overall weakening of the effect of poor periodontal health on dementia, with estimates for tooth loss becoming non-significant. This indicates that at least part of the association observed in the main analysis was due to reverse causality. Does it describe a comprehensive and detailed search for relevant trials? I gave them a partial yes, because they did search the references of included articles, but they did not search the gray literature, and they only included studies that were published in English. Were the individual studies assessed for validity? I also gave them a partial yes here. They used quality assessment criteria derived from a previously published study. However, they did not adequately consider the risk of bias due to confounding, post-exposure interventions, and selective outcome reporting. They also did not specify if the quality assessment was performed by more than one investigator. Were the included studies of sufficient methodological quality? I would say no, given that for cognitive decline, there was an overall high risk of bias, with all but one study being of low quality. And for dementia, there was an overall moderate risk of bias, with still the majority of studies being of low quality. Are the results consistent across studies? So heterogeneity was measured by the I-squared statistic. And with cognitive decline, there was substantial heterogeneity for all exposures except for partial tooth loss. For dementia, there was considerable heterogeneity for periodontal health and periodontitis specific measures, substantial heterogeneity for tooth loss and partial tooth loss, and moderate for complete tooth loss. Are the results generalizable and applicable to my patients? I would say the applicability is limited, given that the majority of studies included participants under the age of 65. And the authors also did not include information about common covariates such as education, socioeconomic status, smoking or alcohol use, depression, and cardiovascular comorbidities. In terms of the strengths of this study, the authors did attempt to account for reverse causality, and they did analyze multiple measures of periodontal health instead of just tooth loss. The authors also stated that a strength of their study is that they generated pooled estimates only from comparable effect estimate types. That is, they did not combine odds ratios and hazard ratios. I did have some questions about this though, because while it can be problematic to convert between odds ratios and hazard ratios, it is possible to do so. And choosing not to do so led to the exclusion of several articles for each outcome, which could simultaneously be seen as a weakness. I would be eager to hear what other people in the audience who have more experience with meta-analysis methodologies think. But from the authors, I would have wanted more of an explanation for why they chose this methodology. For example, was it that they didn't have sufficient information to convert between hazard ratios and odds ratios? So I put a question mark there. In terms of limitations, they only included observational studies. There was a high risk of bias, especially for studies on cognitive decline. The authors did not adequately assess risk of bias from confounding, post-exposure interventions, or selective outcome reporting. They were unable to account for periodontal treatment, severity, as well as the length of exposure. There was a high level of heterogeneity across analyses performed, likely contributed to by the study populations and variable exposure and outcome assessments. And despite their best attempts to account for this, the association that we noticed may still be contributed to by reverse causality. So in summary, this study suggests that poor periodontal health, overall tooth loss, and partial tooth loss were associated with cognitive decline. The same exposures, except complete tooth loss instead of partial tooth loss, were also found to be associated with dementia. However, I'm wary of the results as the quality of evidence is low with heterogeneous exposure and outcome assessments. Furthermore, the applicability to our patient population is limited given the participants that these studies included. Future studies should assess for cognitive impairment and dementia using standardized methods at baseline and follow-up, use standardized methods of periodontal health assessment, account for reverse causality. And the authors highlighted that study types that are currently lacking from the body of evidence include biomarker studies for both periodontal health as well as dementia, and studies of the impact of interventions such as dentures on cognition. So the bottom line for this paper, in other words, was my mom right? No, I'm just kidding. I think it's too early to say we can prevent dementia with good oral health, but given its impacts on speech and social interactions, nutrition, weight and glycemic control, risk of aspiration pneumonia, self-esteem and overall quality of life, I do believe that oral health remains an important aspect of caring for our older adults. I was looking for a couple high-yield screening questions for oral health. However, most of the studies that I came across included very detailed questionnaires or long screening tools, which wouldn't be practical to include in our CGA. In general, though, they did tend to focus on 4 types of questions, which I've included here. However, given time limitations, my inclination would be to save most of these questions for patients where they presented with decreased oral intake or weight loss, or if other concerns for oral hygiene arise, for example, on physical exam. For older adults where oral hygiene is a concern, the Canadian Dental Association has a webpage on dental care for seniors that includes a section on tips for caregivers. And there is also the Ontario Senior Dental Care Program for those with a lower income to help provide them with free routine dental care. Those are my references, and thank you very much for listening. I'm happy to take questions.
Thank you very much, Carolyn, for an absolutely beautiful presentation. The slides were beautiful and very clear. I also really like the stimulation for discussion on probing the methods with the question mark. And I hope Kerry, who has his hand up, may be able to answer that question on odds ratios and hazard ratios. Go ahead, Kerry.
Well, I'll start by addressing that. No, I cannot. But I did want to thank Carolyn for an exceptional presentation. I certainly also enjoyed the humor. So great job. And I think you did a great job. I mean, it's obviously what I call a very dirty study, but which is hypothesis generating, which I think it was meant to be. But I think your critique showed well why it doesn't answer a question, but it seems to certainly brings attention to probably an important issue. And I think it's well recognized that most people don't love attending to their oral care at the best of times. And clearly, with the much higher risk of periodontitis in older adults, the challenge of doing that, I joke with my wife, going to bed every night has now become like a 1-hour ordeal between brushing, flossing, gum massaging, moisturizing, etc. But it's an area that's not well looked after. So it's really good to, I think, put some attention. I'd like to mention that the dental clinic at Baycrest is a major provider to Toronto Public Health. So those older seniors and others of low socioeconomic class, but particularly seniors, because of our focus, are coming to the Baycrest Dental Clinic to have their oral care. And I wanted to ask a question. There's a lot of attention on the microbiome and cognition. And clearly, one might think that people who have poor oral health, the bacteria flora of the mouth may be potentially quite different than in those who have good oral health, which in turn can affect the microbiome and may have impact on cognition. Was there anything mentioned at all in this paper about that particular issue?
They touched on it briefly as one of the 4 potential mechanisms for how oral health and cognitive decline could be connected, but said that there's much more study needed. They were wondering if specific pathogens have a direct impact on the brain, but didn't include much more detail than that.
Thank you. I wonder too, the sample size must be very low in this case, but if it's periodontal health, I wonder if there's a sample of younger individuals who have no teeth for some reason, and whether or not they have a decreased incidence of cognitive impairment due to lack of periodontal issues, but I doubt that that would be measurable or that sample found. Jennifer has a question or a comment, and there are a number of chat box congratulations on great presentation from Patricia Gordon and Deborah Brown. Go ahead, Jennifer.
Okay, great presentation, Carolyn. I just wanted to speak to 2 points, or potentially 3, depending on the time, but certainly 2. So to your question about, why didn't they use some kind of, method to try and approximate, or so that they could pool the hazard ratios and odds ratios together. And as you pointed out, you can do that. And so, they chose not to, which, if that's a decision they made ahead of time, and I'm not sure if you commented, I don't know if I saw this, if they registered their systematic review with Prospero, which is of course kind of like clinicaltrials.gov, and they published their protocol and they said, this is what we're going to do ahead of time, that's fine. But to your point, why not do a sensitivity analysis to sort of test, whether or not including those additional studies and, making additional assumptions that you make in doing the approximations, just to see what that would do to their conclusions. And then the other thing I just wanted to point out, because I really like forest plots, and I'm glad they included so many. So, figure 2 and figure 3 have what we call forest plots, and they allow you to see the sort of whether or not the effect estimates from each study are have a higher association or sort of a lower risk, if you will, of being associated with whatever outcome you might be interested in. And as you pointed out, you looked at the I-squared and you're like, those are pretty big numbers. That's a lot of heterogeneity. But at the same time, even just from looking at those forest plots, you can see there's a lot of differences, like especially in figure 3, sometimes the association is towards a higher risk of dementia. Sometimes, it's more leaning towards the lower risk of dementia. And it would have been really nice for the authors. And you pointed out, you said, well, there's going to be different potential confounders, and these are observational studies. So, different studies could have considered different factors or not considered important factors, like some of the social determinants of health that you talked about. And so it would have been really nice if the authors, or maybe they do have something that I didn't see, and you might be able to comment on more. But, if they were able to say, why did some studies show such a higher risk and others had a lower risk? And, what were the factors that each of those studies included or didn't? That would have been another important point. But yeah, there's lots of things to comment on, as Dr. Negley said, but to me, those are just a couple of the highlights.
Thanks so much, Dr. Watt. So the authors unfortunately didn't comment on why we see this difference here. I'm not sure if this is the one that you were referring to.
There's lots of them, so that's a great example.
So, however, I did look at this study on its own, and it actually links to what Dr. Gandel mentioned in passing just now. And this study had many more participants with more missing teeth at a younger age. And they did wonder that if tooth loss at an earlier age, that may be associated with the lower risk of dementia, because you don't have tooth loss and periodontitis contributing to systemic inflammation in your later years. So they were actually wondering if that was why the results, or I wonder that if that's why the results here are different compared to the other studies included in this forest plot.
Thank you.
Great. Thank you very much. I'll mention too that Sunnybrook has a dental clinic as well that serves marginalized populations also. So thank you again, Carolyn, for a wonderful presentation with excellent practical tips. Are there any other questions? There's a comment from Vaishnavi Raman. Thank you for your talk and for these practical tips. Any other comments or questions? If not, again, I apologize that this morning's Journal Club is one presentation only. Dr. Chen will be back in January to present on haloperidol and delirium. As by way of announcements, please remember to complete the evaluation for this morning's presentation. And I wish everyone a very happy holiday season. And we hope to see everyone back in 2023. Thank you, everyone.
Happy holidays, everyone.
Happy holidays.